So one of the things that you'll notice on his history is that his creatinine is 2. His GFR is 46, so he's got some pre-existing kidney function abnormalities, and so we have to be we have to be sparse with the diet, and that makes things more complicated because it's harder if you can't see. So let's go through the next slide. Okay, so what you can see on this angiogram of the right coronary artery is right at the end of the right artery where you see those branches. Both of those branches have a tight lesion. All right, so the first thing we do is we get access with this micropuncture needle in the leg, and you can see what we're doing is we're just taking a picture of where the needle enters into the artery. And that documents that we should be in the right position. Okay, this is us measuring the end diastolic pressure. The end diastolic pressure gives us an idea of how what the volume status of the patient is. Is the patient need fluid? Do they already have too much fluid on board? And this is standard practice for all of our patients, but it's even more important in patients who have advanced chronic kidney disease. Our group actually showed that what we think is clinically, whether we think the patient's volume over or not, is completely wrong, and it should be completely guided by the end diastolic pressure. And in this situation, it was 13. So right where we want it to be. It should be somewhere between 5 and 20. 13 is perfect, so we didn't need to push fluids anymore.
And it's about 30 seconds to get that at the beginning of the case, and really it just helps to give a lot about the whole volume assessment for the case.
So this is our only picture, all right? So this is setting up basically the blueprint of the house, and so this architecture is now going to guide us throughout the entire procedure. Okay, and so then what Evan is doing is now he's wiring these arteries based on this dynamic roadmap. And you'll notice something very important. You see at the end of the wire there's a loop, okay? He's purposely made that loop, and the reason is that loop makes sure that we don't exit the artery. Remember, we're not going to be using lots of pictures. So the loop is a great safety mechanism for us to make sure that we don't get a distal wire perforation.
So between IVUS and NAVUS, you can assess everything. The only thing that we can't see is if there's a distal wire perforation. So as long as you have that loop, you know you have that safety margin, and we're not going to do any puffs throughout the case.
And so there goes our second wire in, and what we did is then we pre-dilated this lesion with a small 2.5 balloon. There's the balloon going up, so soft plaque. We did this before we IVUSed. And then what we did is we went ahead and IVUSed. There's the NAVUS catheter, sorry, the Kodama catheter. And the Kodama we did from both branches to look at inside, and we'll show you those in just a second. And there's the second. I'm going to stop here and then ask you to go to the IVUS. Okay, so what you're going to notice here on the IVUS is Evan has put his foot on the pedal exactly where the artery is normal. So if you look at the IVUS, you have a perfect circle with no plaque. Okay, so we've co-registered the normal part of the artery to the angiogram based on the IVUS catheter. And then what we do is scroll through the lesion.
So this was the IVUS and the PDA. Now we'll show you the second IVUS, which is from the RPLB. Distal reference, again, you see that we have a healthy landing zone, no plaque. Just proximal to that, we start to get some eccentric plaque. Minimal calcification, just continue going proximally. Soft plaque, so extensive soft plaque here, even after pre-dilatation. You see at 12, 1 o'clock, that's our bifurcation. That's a true bifurcation with the wire coming in from the PDA. And then proximal, this is the distal RCA with a little bit of plaque that we decided to cover it, so this way we're treating from healthy to healthy.
So why don't we walk you through how we make the measurements here. So if you remember, Evan marked the distal reference with this with a dry Sine, and now what we're going to show you is how we make the measurements. So we know we want to land at that spot. So that's one measurement. That's the size of the artery. It's 2.47, and in the other direction it's 2.89. And so now we're going to scroll through the lesion until we get to a normal segment in the proximal part of the vessel, past the lesion, which is. There's the bifurcation, so we bookmark that, and then we're going to come to a normal artery. There's a little plaque here. This is starting to look like a normal artery, and we'll stop here. So this will be our proximal landing zone, and then we'll make a measurement here,
And you know, one thing about the ostium you saw of the side branch there's no diseased osteolae, and that's very important because we're stenting across. That's why we went with a provisional strategy. We felt very likely that there wasn't going to be significant plaque shift, and the side branch would stay open osteolae.
So we made the measurements distally of how big the artery is, and the measurement proximally. What's missing is we don't know how long this lesion is. So we can get that again by IVUS. It's very accurate. And so what we do is just click on this, and then we're going to use the length tool and go all the way to the proximal marker. Okay. And so the proximal marker is taking us, now we don't have a 25.8 millimeter stent, right? So what we're going to do is bring this to a commercially available stent size and see where we land. And so we have a 23 millimeter stent made by Abbott, so that's going to be our new proximal marker. So that's how we take a qualitative assessment and make it quantitative. Finally, we want to make sure that we have enough room proximally to be able to use a balloon because of the size discrepancy distally and proximally. Proximally, we've got an 8 millimeter balloon. So if we summarize, what we learned from the IVUS was the following: that the distal vessel is 2.5 millimeters in diameter. The proximal vessel is 3.5 millimeters in diameter. We need a 23 millimeter stent. We need a 2.5 millimeter non-compliant balloon to open up the stent distally, and we need a 3.5 millimeter balloon to open up the stent proximally. And so that's exactly what we did. Let's go back to the angiogram. Okay, and so there's our stent going in here, and then this is our balloon right. Let me show you here, right? That's just moving our balloon in the right spot. Okay, there's the balloon in the front. That's the proximal balloon, which is bigger. And then we did a post-IVUS. So let's show the post-IVUS, please. Do you want to walk through the steps of MAXF?
Yep, so any intravascular imaging run, we have a pre-procedure MLD, as you saw, for morphology, length, and diameter. Here, we're looking for optimization. So it always starts with M for medial dissection. We start at the distal edge, make sure there's no edge dissection. We saw that's fine. Then we go to the proximal edge, make sure no dissection. A is for apposition, so just quickly peruse the vessel, get an idea if there's any significant malapposition, if that stent strut's touching the wall. In this case, you have full apposition, which is very different from expansion. So the X, the final step in optimization, is looking for expansion. So what we do is we find the MSA, or minimal stent area, that is being highlighted here in this cross-section. We'll take a measurement there, and then we compare that with the distal lumen reference. And what we're looking for is about 80% or more expansion. Most of the stent, the proximal distal portion of the stent, is very well expanded. But that one mid portion does have under expansion, and that's not that surprising because we post-dilated the proximal portion, proximal to bifurcation. We never post-dilated this region. So it's helpful. It tells us we need to go in, post-dilate very focally there. What's also nice, the IVUS shows we don't need to post-dilate at the edges, so there's no risk of an edge dissection this way. And we're doing targeted therapy exactly where you need post-dilatation, as opposed to just indiscriminately doing post-dilatation. So we get our sizing based on the IVUS, and as a result, we went in with a 275 NC balloon at high pressure, just in that focal area to treat that.
So what we'll do is we'll do a final IVUS here of the PL.
Yep, so here you see our IVUS in the PL. So distal edge, no dissection. We see, yep, pull back, please. So distal, no dissection, no significant edge disease there. This is now well expanded. That was the region where we had that under expansion, so much better.
And I think so you measured the minimal stent theory previous at
and then approximately no edge dissection.
So let's see what it is
no
now.
disease.
You see it's significantly better.
Coming out with IVUS.
So we went from 3.1 to 4.5 or 4.4. So that's obviously a significant increase. And this is the benefit of intravascular imaging. If we did this with angio guidance, we would have said it looks fine and we wouldn't have post-dilated. But we remember the smallest part of the artery is the rate limiter. So your risk of having a failure at 3.1 is orders of magnitude higher than if you're at 4.5. In fact, 4.5 is kind of the cutoff, which we showed is the gold standard for where the risk starts to decrease. But Evan and I had one other problem, right? And that is we put this stent, go back to the angiogram, right across that branch. And so the question is, we don't know whether or not we pinched that branch or not. So can we have the angio back?
So what are our options? Option one, take an angiogram, give some additional contrast, see if there's any pinch, see if there's any distal edge dissection, or significant residual disease. Realistically, what's going to happen if we saw a pinch, we probably then give nitro and want to see if it goes away, repeat that image, give another 4 or 5 cc's contrast. The other option, one of two things. One, we can do IVUS. 2, we can do a physiologic assessment and see if there's any significant gradient. So as we were crossing with a Navis catheter and doing a physiologic assessment at first of the PDA just to see, and that PDA, if you can show that, we had was 1.0. And then we went in the main branch into RPL where we stented and also confirmed that there was no gradient. Our PDPA was 1.0. So both showing we have adequate flow. There's no further optimization that we need to go after for either vessel.
So basically, we did a complete revascularization on this right side with both imaging and physiology guidance with 3 cc's of contrast.
In a bifurcation lesion.
We didn't leave any there was no guessing, right? We didn't guess whether one lesion might be okay. We didn't use an angiogram. We used pressure and imaging to make sure that we've done an optimization. We don't want you guys just having
a final shot.
So you want to see the angiogram, right? So we'll give you a little bit. Let me just flush it. So what we do with the assist is we just give a little puff until we see, because we're recording every measurement, okay? So some contrast just went in. So I know right now how much is delivered on each injection. So we injected 0.8 mils. So now Evan's going to take a cine and I'm going to do an injection. And that's it. Okay, so our last injection was 4.4 mils, and that means that the team can actually record that. So in this vessel, we used a total of 7 milliliters. No. So this case was done with the assist system. One of the nice things about the assist system, both in intravascular imaging and physiology. Intravascular imaging, high definition IVUS, very high quality. Physiology, we did with the Navis microcatheter. So you don't need to use, you can use your dedicated workhorse wire and just use the pressure catheter as your measurement tool. And then finally, the injector itself, I think, is a great help. Number one, it eliminates the risk of air. It's been used in over 50 million patients globally. And what that really does is A, eliminate error, B, keep an accurate record of the amount of contrast you've actually used. Because every time you press the button, it records it, and as a result, a lot of tools are made by Assist that I use for these ultra-low contrast cases. Thank you so much.
Thank you. I think that this is really great to just